Welcome to my channel. Like, share, and subscribe. Then we begin. Welcome to Critical Care Nursing Studies session with me.
Hi everyone, welcome to my study session. I am Tochi and I'm literally in my library. I wish I could show you around, but there are other students and well, I don't want to take the picture, they didn't give me the permission. So preparing for my critical care exam. So today we're going to be breaking down acute respiratory failure, and I'm going to teach it in the way I wish someone, but I'm going to teach it in the way I understand. If you're studying for NCLEX, prepping for critical care clinicals, or just trying to understand why your patient can't breathe, then this is for you. We got about an hour together. Maybe 45 minutes an hour together. I'm going to explain 5 main causes of respiratory failure, what you actually see in your patient, and how to answer these tricky and class questions. So grab your note and let's do this together. So I have my own notes right here with me. So I love notes that have like positive affirmation. So we're going to be going through this together. Before I started this, I had like my topics. I don't know if you can see it, but I have so many things to go through with you guys. So grab your notes and let's start. So what is acute respiratory failure? Okay, so let's sit on the board. The textbook we use is the sole one. I'm gonna show you later, but this is the idea. So this is the lungs. Let's say this is the lung. Okay, fine. It doesn't look like the lungs, but I'm not the best artist. Okay. So RAF, which is also acute respiratory failure, is when your lungs can do their two main jobs, which is to get oxygen in, oxygenation failure, and then to get carbon dioxide out, ventilation failure. So literally this is what it means. Okay. I'm someone that like to think of a way I could make two things work together. So basically, I think of ARF, that's acute respiratory failure, like your lungs are like Amazon warehouse. Oxygenation is getting the packages in, and ventilation is getting the trash out. Now, when the system cannot work, you have problems. That means you can get packages into the warehouse to distribute to people that have ordered these packages, and then when you have accumulation of trash not being taken out, we have a problem. So what are the main causes of RAF? So there are like 5 main causes of acute respiratory failure. There is hypoventilation, shunting, vacuum mismatch, diffusion defects, low O2 in the blood, which is a non-lung issues. So we're going to break it down. Hypoventilation, it's you're not breathing well enough. You're not breathing enough. Let's say if you're expecting a chef to cook food and they're sleeping. This is like one of the easiest reasons is because the patient is not just breathing enough. So when we are talking about hypoventilation, you're thinking of drug overdose, you're thinking of post-surgery, and then you're thinking of when they have neurological issues. So when I say neurological issues, I mean like stroke, head injury, drug overdose like opioids, sedatives, post surgery, like, effect of anesthesia. They're just groggy getting out of anesthesia. So if NCLEX asks about respiratory failure with drug overdose, what should you think first? You think hypoventilation, not breathing well. What's on the list was pulmonary shunting, which is basically the blood goes from the right side of the heart to left side of the heart without getting oxygen. Okay, and then it leads to hypoxia. Not hypoxia, hypoxemia. It's like not having oxygen in the bloodstream. This is not good. Basically, the blood flow is bypassing the lungs, which is key in helping the respiratory system. So Giving more O2 does not help shunting. Why? Because blood never touches the oxygen. I don't know if you get this. So, if you see a patient getting tons of oxygen, like they're getting the full 15 liters on non-rebreather, but they're still hypoxic, think shunt. They are shunting. They have the left shifts, voodoo. That's what they use in the old times. But the potential things that could be causing this interpulmonary shunting is our pneumonia. Think of alveoli like grapes. If they have pneumonia, this is infected alveoli, plus pulmonary edema, right, which is also fluid filled. This is filled with fluid alveoli, and then atelectasis is like collapsed alveoli. And then a critical point to know that's also active defects. I don't know if you know the active defect, septal defects, atrium defect. They are also more likely to have this interpulmonary shunting thing, the TOF, which is the tetralogy of Fallot's. Yeah. Anyways, that is a whole big topic on its own. I am not going to go that deep. So, person think, why wouldn't increasing oxygen help blood if it's bypassing the lungs? Think I said the answer. It never gets exposed to oxygen. So we're going to clean this one, and then we're going to talk about the VQ mismatch, which is the next causes, which is another cause of ARF. So the VQ mismatch is the most common cause, but it's somewhat difficult. But pay attention so you don't miss anything. So in the VQ mismatch, V is for ventilation, which is airflow. I don't know if you can see my handwriting. I'm trying to make it very readable. And Q is for perfusion, which is blood flow. So airflow over blood flow. Okay? And the normal ratio for this is 4 liters per minute. And not ratio, the normal expected normal levels for this value is 4 liters for the ventilation and 5 liters per minute for the perfusion. And then the normal rate for the VQ is 4 over 5 equals to 0.8. Okay, so now let me give you a scenario. So let's say tables is saying yes, then customer is saying no. Ventilation problem is no airflow. There's no airflow. And then when this does not match up, so maybe you have air, the airflow, but you don't have blood. You get hypoxemia. God, that is not a good handwriting. Okay, I'm going to rewrite this. It looks weird. Okay, you get hypoxia. Okay, yeah, you get hypoxemia. Okay, so now what can cause this VQ mismatch? A lot of situations can cause it where there's PE, that's pulmonary embolism, that's this blood clots in the lungs, and then the perfusion from the lungs to the heart is blocked. Or you can have pneumonia, ventilation is blocked. Remember, ventilation is airflow, perfusion is blood flow. So when you have pneumonia, ventilation is blocked, no airflow. And then COPD, both of them, there can be no ventilation or no perfusion. And then mucus plugs, it's basically when you have mucus blocking the airway. And so most of ICU patients normally have the VQ mismatch, also known as ventilation perfusion mismatch. So diffusion defects, we're now here. It's the barrier between air and blood. Now, let me explain that. I got tired of holding the phone to the board and writing at the same time. But basically, diffusion defect is a barrier between air and blood. Think thick windows. There's no ventilation. It could cause pulmonary fibrosis, fluid in alveoli. Remember, also the interpulmonary shunting also has that fluid in alveoli, which is where we have the pulmonary edema. But I don't know how I'm going to share that one, okay? Yeah, I'm going to share my notes after so that you can see what I'm talking about. So now, to go to the second part of it, the low O2, oh no, it's weird, never mind. The low O2 in blood is, that is when there's decreased O2. Now for the low O2 in blood, non-lung issues, when I say it's non-lung issues, that means this is not the lung causing it. It means there's low cardiac output, that means the heart is not pumping blood around, and then there's low hemoglobin, nothing is carrying the O2. Remember the O2 is 95% of oxygen rides on hemoglobin. Think of hemoglobin as the transportation for oxygen. And normal oxygen saturation, 95 to 100%. So the problem is the fewer red blood cells is equals to less oxygen transport. And then this is what causes the low O2 in the blood. If you remember earlier, I showed about altered gas exchange, which is the ventilation. So because I was focusing more on the failure RAF, now we're going to be talking, I was focusing on the failure of oxygenation. Now I'm going to be talking more on the failure of ventilation. When you can get O2 out, what happens? The PaCO2, which is the normal rate is 35 to 45, is greater than 50 mmg. So they are in a state of hypercapnian. A lot of medical terms is not easy to pronounce, but I try my best. And then the pH drops. That's the blood pH level drops, and then they're in respiratory acidosis. Remember, alkaline and acidosis. So the minute it drops, acidosis. If it rises up, alkaline. Remember, the pH is 7.35 to 7.45. And then when the pH drops, patients get sleepy, confused, and then they're in carbon dioxide narcosis. No good, no good. So what can cause this? Alveoli hypoventilation. They're not moving enough air. So think of when someone is in a panic attack. They keep breathing in, but they're not really getting air because they're anxious. That's the word. They're anxious. Then the VQ mismatch, we talked about it. So it's dead space. There's ventilation, but there's no blood flow. So now we're going to write on the board. We're going to talk about assessment and signs. I decided that writing on the board is going to take a minute, so I don't have that much time because I have to finish this and catch the bus to get home. It's getting late. I don't know if you can see, but yeah, it's getting late. So, assessment of respiratory failure. How do you know they're having respiratory failure? What are the signs to look for? What are you expected to see? I am going to tell you all of that soon. Let me bring up the PowerPoint. That is loading, and I'm going to share my screen with you. So bear with me. I am just like going through and making sure I have everything. Okay, so when there's any issue, the first system to show sign, well, if it's related to the heart, the first system is definitely cardiac. You know it. The heart related, the first one likely to show sign is the kidney, because the kidney loves perfusion, it loves blood, it loves to have everything. Anyways, we're not talking about that. We're talking about respiratory failure. So the first one you're gonna see sign is your neuro. So if you have a perfectly okay patient, then all of a sudden they're restless, they're anxious, they feel like they're not breathing enough. That means you're having respiratory failure. They're confused. All of a sudden, they're AMS, altered mental status. They're agitated. They have poor judgment. These are all early signs of hypoxemia. Late signs is very bad. They're very sleepy. They're in coma. They're having seizures. Not good. Let's see. Another one, the next system obviously will be respiratory because it's happening in that system. You would see shortness of breath, you would see fast breathing, you would see use of accessory muscle. Remember, your accessory muscle is your own diaphragm. They're going to be trying to compensate. They're going to have abnormal breath sounds, and they're going to have sinuses. But beware, sinuses is bad. It's late sign. That's like if you didn't catch up all the signs, then something, is wrong. Cyanosis is when they turn blue, like literally blue. They're looking pale, they're looking blue, basically blue. That's cyanosis. Cardiovascular, the signs you see in cardiovascular is basically early sign is when they're compensating. The body starts picking up strength, it's in survival mode, and then you see fast heart rate, tachycardia, and then you see hypertension. The blood pressure is going to shoot up. That's the early sign they're compensating. But when they're tired, they've been working hard to compensate for all of this, then everything crashes. It's like when you have, when you get high, like when you drink so much alcohol, you're high, you blah, blah, blah. When you crash like when you wake up the next day, you're having anger. You're like, you can't wake up, you can't walk straight, you can think. A lot of things is going. I've never gotten drunk, but I know because those are the signs and symptoms noticed. But That's it. It's like going from a high and then boom, crash. So they have bradycardia, the slow heart rates, and then they have hypotension, low blood pressure. Those are late signs, and that is when it has gone severe. The body is not compensating, like things has gone, it's beyond something you can handle. So what are the nursing interventions? Remember, our priorities is always A, B, C, Ds. A, airway; B, breathing; C, circulation; D, differential diagnosis. Now, when you say priority actions, what are you thinking of? We're thinking of maintaining patient airway, optimizing oxygen delivery, and minimizing oxygen demand. This is a very important one, especially since we're dealing with respiratory. You want to always reduce patients' demand for oxygen. What are the things you do? What are the steps? What are the actions you take to help these patients? We'll come back to that later. So you also want to treat the underlying cause, that's the root cause. You want to get to the roots. It's just like your HNTs, and then you want to prevent complications. What do you think could happen in this situation? A lot. So you want to control it early before it gets to a point where we can save these patients. So medical management, you want to do your oxygen therapy, put them on O2, um, bronchodilators, the medications that help you to open up your airways. Corticosteroids is to help reduce inflammation. But beware, corticosteroids increases blood sugar, and then corticosteroid is not fast acting. But your bronchodilators, you always want to give that first. This is fast acting and it's going to like open the airway. A corticosteroid takes a minute, takes a while before it kicks in. Mechanical ventilation, that is when the patient is no longer breathing, they are on machine, they're depending on this machine to breathe. That would be like a last resort. Like if you've done everything and they can't do it, you put them there. It's a last resort because it's invasive. You always want to do minimal invasive to you want to do non-invasive to minimal invasive before you get to invasive, because sedation is to help them calm down. You could give, well, sedation is to help reduce anxiety and reduce them requiring more oxygen. Because when you're anxious, you're hyperventilating, and when you're hyperventilating, you need more oxygen. So that's going to help. Nutrition support. When they say nutrition support, if this patient cannot eat by themselves because they're having a airway crisis, we're going to be thinking NG2, OG2. So it's depending on pros and cons. You're going to wait. Blood transfusions if needed. If the patient is having a situation of low O2, we're going to give them blood. I mean, we have a situation of low hemoglobin, we're going to give them blood because blood has hemoglobin, and hemoglobin is oxygen carriers. And when we have oxygen carriers, it's going to help with the oxygen transportation throughout the body. And then we're going to monitor them. We're going to monitor their vitals. We're going to monitor everything. Ways to reduce oxygen demand. Good. And I was talking about, it's one of our nursing interventions. How do you do that? Well, you control your fever. When you control your fever, remember, fever comes as it's our body system for kicking. It kicks in. It's like, oh, something is wrong, and then you have fever. It's telling you something is wrong. It's making you know that something is wrong. It's a response. So it increases the metabolism. You want to manage pain and anxiety. You want to promote rest. So limit unnecessary activities. This is where you want to do cluster care. When you cluster the care, go once, and then give them some time before you go and cluster the next set rounds of care. You want to position properly, probably in semi-fowler, which is like 30, 45 degrees up the bed. You want to prevent shivering, because shivering is using up, your body is working out to make you warm. When you're shivering means you're cold. So when you're cold, your body is working out more to make you warm or to bring you to regular temperature. So you want to prevent this by getting them one blanket, warming them up. Now we're going to go to ARD. So when I was talking about the book I used, this is what I meant by Souls. This is Souls Introduction to Critical Care Nursing, 9th edition, because currently my critical care nursing. So the topic we're talking about was acute respiratory failure, ARF, and this is it. So this is the topic. Basically, this is what I summarized. The part that was the failure of oxygenation. These are the 5 causes of it: the hypoventilation, the drug overdose. Interpulmonary shunting is when the blood goes from the left side of the heart to the right side of the heart without going through the lungs. They bypass the lungs. The ventilation perfusion mismatch, as a VQ mismatch, is basically when if ventilation is airflow, perfusion is blood flow. This is the diagram explaining the alveolus when it's more than one. I think of the alveolar like grapes. So imagine how a grape looks. This looks like a shrink grape. That's when it's collapsed. That's also known as atherosclerosis. Oh my goodness. Basically, this was what I was saying, talking about low cardiac output, diffusion defect, and then low hemoglobin level. Hemoglobin is the transportation for oxygen when there's low
hemoglobin. Then tissue hypoxia is when like there's not enough God, I just woke up and I'm doing this. But basically, this is it. This is what we're talking about. I was hoping to see like pictures of what I was talking about, and then I haven't gotten to this part. I said I would do another video for the acute respiratory distress syndrome (ARDS), which is somewhat like COVID-19, but so there's not a lot of diagrams. I was hoping for diagrams or something. But anyways, that's it. And then I decided not to overwhelm you guys with so many topics. I'm going to leave our ARS, ARDS, which is acute respiratory distress syndrome, for another time. Thank you for studying with me. Till the next session.